Good morning. My name is Niccolo Piazza. I'm an interventional cardiologist from Montreal, McGill University Health Center. And for today's session, Monday, November 22nd, 9 o'clock a.m., we'll be speaking about the HighLife transcatheter transseptal mitral valve replacement system. And it's going to be an interesting session. I'm joined today by our moderator, David Hildick-Smith. Good morning.
Hi, Nico.
And also, we have live our discussant, Steve Worthley. Welcome.
Nico, thank you for having me.
And we also have Wolfgang Rottbauer from Ulm. Good morning.
Good morning, Nico.
Very nice to see you.
Here.
Okay, so we have a few objectives to cover today. What we're going to do is we're going to see what is the HighLife transseptal transcatheter mitral valve replacement system and what is its concept. We are also going to see a live in the box that's going to be presented. So it's going to be a full case presentation. And finally, we'll see the clinical data and what are some of the upcoming future iterations of the device in order to meet some of the challenging anatomical situations that we've been encountering in clinical practice. So why don't we begin, David, by maybe telling us how people can interact with us?
Yeah, so we have Zenon Huczek in Warsaw, who is available live, ready, willing, waiting to field your questions. He will answer your questions directly, or if there's anything particularly pertinent, you get fed through and Nico will give you an answer. So do speak to Zenon. He's done a number of cases himself. He's experienced in this procedure. Do chat with him online.
Yes, and I think it's important to mention that all of our participants today, our discussants, have all performed the HighLife procedure, so we can have some nice discussions. Okay, Stephen, why don't we begin with the first lecture? Tell us a little bit about the HighLife system and how it works.
Thanks, Nico. Look, it's a pleasure to really give a pretty brief overview of what the technology is, why it's unique, and how it works. That is my disclosure slide. One of the issues we know about transcatheter transseptal mitral valve replacement is that the mitral valve anatomy is different and unique from that of the aortic valve. As you all know, the aortic valve is encased within a fibrous skeleton, the fibrous trigones, the aortomitral curtain. So it does lend itself well to having a stent frame placed and secured within it. Mitral valve, different. There is a very thin fibrous annulus, but it doesn't provide that same skeletal security as the aortic valve. And so one of the challenges has been, how can we seat and secure a stent-based frame within it? The HighLife concept utilises this ring as well as a stent frame, where the ring forms a number of structures. It encompasses the cords and the mitral valve structures itself, and it acts almost as a pseudo-annulus within which the stent frame is delivered. More than that, though, what it does is, apart from providing that security for the stent to be delivered, it actually gathers up the mitral valve structures themselves and actually creates a seal, so that it mitigates paravalvular leak occurring around it. So two roles that this ring plays. One, it acts almost as an annulus to create the security, but second, it creates a paravalvular leak security from within the frame. It's a pretty simple, straightforward procedure, really, when you break it down into its steps, and there are three main steps that are used to perform the procedure. One is this, what's called a loop placement, where at the moment, retrogradely via a femoral artery access, a catheter is positioned just ventricular side of the aortic valve, and using a Terumo glide wire, we encapsulate and capture all of the cords, and that then permits us to deliver this subannular implant or ring-type structure that is then secured from the ventricular side just underneath the mitral valve as step 2. Step 3, then via a transseptal puncture using femoral venous access, the stent frame itself is delivered, and you'll see on the fluoroscopic image to the right of screen that two things are really evident on the left ventriculogram. One is that stability of the transcatheter mitral valve replacement created by the ring structure, and the second is the complete abolition of mitral incompetence in this case. In the middle of that image, you'll also see and appreciate the endothelialization that occurs all across that stent frame in that chronic animal explanted example. So a summary of the procedural pieces are, by having this anchoring happen, there is no need for barbs or hooks. Now that's important because one, what that does do is immediately mean that the French size of the delivery system will intrinsically be significantly less, but also it comes to safety. There's no need for sharp or structures that may actually potentially cause injury. That ring I mentioned gathers up the cords and the mitral valve apparatus as well, so it creates the absence of paravalvular leak. But by tethering in particular the anterior mitral leaflet, it also mitigates the occurrence of systolic anterior mitral leaflet movement that you might see some SAM and therefore accentuate any left ventricular outflow tract obstruction. And so by having a dedicated delivery system for that ring as well, it allows us to break this system and the performance of it down into those 3 simple, easy steps. My last slide, really what this current platform does permit us though is to potentially iterate and improve significantly in the near future. Transesophageal echo will be able to be replaced by intracardiac echocardiography. Indeed, the procedure itself is quite fluoroscopic. The requirement for echo imaging is helpful, but not really the key part of the procedure. And therefore, with ICE, we'll clearly be able to look at local anaesthesia and reducing that part of the procedure. But also there's going to be some increase in terms of the number of valve sizes, so that for patients that have a need for a much larger valve size, we'll be able to cover that. But even patients that are at risk now for left ventricular outflow tract obstruction, there is a valve where much of the skirt's removed, the clarity valve, and in fact that will, I think, be a solution for those patients. And indeed, by not needing barbs or hooks, the opportunity for us to downsize this system further also exists. So, in summary, an exciting technology, truly transseptal for this transcatheter mitral valve replacement. Thank you.
Thank you very much, Steve. So again, please, anyone live in the audience or joining us virtually, please send any questions if you have through the chat. We'd be willing to answer any questions you have. Stephen, you know, of course, the highlight of the HighLife valve, I should say, is the fact that we have a ring concept, a docking system. And so you had mentioned that perhaps we don't need oversizing against the annulus in order to get anchorage. What do you think are some of the advantages of this ring in particular?
Yeah, thanks, Nico. Look, we touched on some of the pieces before around the stability and the mitigation of paravalvular leak. Nico touched on this too, that obviously I've had the pleasure of being involved with 8 cases to date, and it's actually been really striking, Nico, that there's no, I've not seen paravalvular leak in any of these cases, and a very stable device implant, which I think is, you know, when we look at the durability of this system, what it will potentially do in terms of having any adverse outcome, it just gives me some comfort that this is going to be a very stable and benign implant in the future.
Yeah, yourself, David?
Yes, I mean, the thing that strikes me about this technique and this system is that with the ring in place, it's so important that it allows you to expect no left ventricular outflow tract obstruction, because that's sort of the Achilles heel of mitral intervention. The mitral valve opens, and if you stick something in the middle of it, the anterior leaflet, stays open and will block the LVOT in many cases. So the fact that you have a smaller ring, which allows you not to extensively oversize the valve, and that anterior leaflet is sort of tethered in around the valve cage, means that actually the unique selling point is this should be applicable to very many more patients than some of the other technologies which don't have that encircling ring. So that for me is the key distinguishing feature.
Wolfgang, anything from your side with respect to this ring concept or valve in a ring concept?
Yeah, thanks. I think most of it is said, but I think another intriguing feature is that we are not really touching the native annulus of the patients, and it will be interesting to observe what happens to remodeling of the left ventricle. And I think this is also a very intriguing feature, putting in a neo ring and getting a sealed valve without touching the real anatomy.
All right, so I think if we'd have to summarize, you know, the comments that were just made with respect to this ring, one, it appears that with the ring and its apposition of the leaflets against the frame, it mitigates the risk of paravalvular leak. David, you had mentioned that the ring sort of holds back the anterior mitral valve leaflet and perhaps mitigates the risk of SAM and LVOT obstruction. And Wolfgang, you had mentioned the fact that the valve really doesn't anchor against the annulus. There's no oversizing, really. And that's an interesting concept as well, because if you don't have to oversize, you don't have to create large valves, and that may allow you to create smaller delivery catheters. Okay, very good. So, Wolfgang, why don't we move over to you and maybe show us your live in a case?
Okay, I'm happy to. So somebody has to start the slides. So we go right into a live recorded case, and it's cut it in pieces, so everybody can follow the stages of the procedure quite well. Here you see the patient we treated, a 83-year-old male. We are functional class 3 to 4 with severe, mainly functional mitral regurg, severely reduced LV function. The patient had a history of coronary artery disease. Here you see the pre-screening slides. So we focused there on annular dimension of the mitral valve, as well as on the outflow tract area that is measured with the Trimentio system after pseudo-implanting the valve. Another important feature is that we get vascular access, usually to the left femoral groin. And here you see the measurements are used from TAVR CTs. The next thing in procedural planning is that we are working with chamber views similar to the echo, and we simulate them also in Trimentio. You see there are 1, a 2, a 3, and a 4 chamber view. And here you see on the slides at what different steps of the procedure we use what views, for instance, loop placement and loop verification, mainly in the 1, 2, and 3 chamber view, and usually wire position in a 4 chamber view. So here you see the real procedural steps from access to loop placement, transseptal puncture, ring placement, and valve delivery. Usually a procedure takes about 2 hours. The video goes quite fast. I'm sorry about that. So here we are in a 3-chamber view in a live case on the fluoro, and you see the wire tube pointing towards the left. It's already out of the loop placement catheter, and the snare tube towards the right. Here you see a 1-chamber view now. The wire is already out and it's pointing towards the right direction on the mitral annulus. Now the system, the fluoro arm is moved to a 3-chamber and 2- and 3-chamber view. Here you see the 2-chamber view, and we already almost managed to enter the aorta, which is marked with the pigtail catheter in a non-coronary cusp. So here we control again our hypotube that is following the looping wire on a 1-chamber view. This is a classical 1-chamber view that helps us to get a feeling about the orientation of the wire. And as you see on the left upper corner, we have echo true imaging to also follow the procedure, although fluoro is the most important imaging technique to guide the procedure. Now the wire is pointing towards the left ventricular apex. You see that? So then it needs some corrections. We will bring back a little bit of the wire and the hypertube and then orient ourselves now in a 3-chamber view. Again, you see that the wire is moving more now towards the left ventricular outflow tract. And during that procedure, it's important not to get trapped with the wire in trabecula of the left ventricle. And now it looks already pretty good. We lose position again. Now we are below the aortic valve with the wire, and soon we will exit the left ventricle. You see that here clearly, and we now enter the ascending aorta. Now we bring back the loop placement catheter into the ascending aorta, and now moved out of the snare tube, the helicopter snare. And you can see nicely the wire going up and down within the ascending aorta. And usually we try to catch the wire now with a snare in the ascending aorta of this patient. This can also take once in a while some time. And you see that here you need several tries. Usually you don't lose your looping position of the wire. You can stay in the ascending aorta. Now I think we cross the snare. We close the snare now, and we catch quite some wire. I think we will follow the wire now, and you will see then later on that it goes into the carotid artery. There is no harm to that, but we want to have quite some piece of the wire there safely secured with a snare. Here you see that. So this is enough. And now we will tighten the snare. And now the next step will be the so-called cinching maneuver. We do that then in a 1-chamber view. We bring back the loop placement catheter below the aortic valve into the left ventricle. We're still here in the snaring process, but we'll switch then to a different. Here you see now we start the cinching, and you follow now on the fluoro and on the echo, the cinching maneuver. So we will pull on the wire tightly, keep the snare tight too, and make the loop very small and see if the wire is centralizing both in the fluoro and in the echo. And you saw that we are not trapped at any place within the ventricular wall with that wire, and that's an important information. Now we already are using the ring placement catheter, and you see the ring has 2 ends, one a barded arrow or hook-like structure that goes into the other end, this is a special catheter that brings a ring, a rubber-like ring around the wire placed. Now you will see the closing of the system, and then we show that to you then more than once, but usually once you closed it, the barbed hooks are not allowing for opening again. Here you see the first closing of the ring, and I think we show you a video here to show it again to you. But now at this stage, it's already closed, and for safety issues, this maneuver is repeated 2 to 3 times in high magnification. You see it here again. So there's some tension on the ring, and it closes very safely. And during the study, none of the rings ever opened. So you see already that there is a safari wire within the left atrium between the wire looping and the ring placement, we usually go with the transseptal puncture first to be prepared then for valve emplacement at the next step. So now we remove the ring placement catheter, bring it back towards the descending aorta, but the wire is still in place within the ring. You see that, and we like to have it that way. And now we will change to a 4, or in this case to a 2-chamber view to cross with the help of an Achilles sheath, a pigtail catheter. It's barely seeable through the ring into the apex of the left ventricle. Then we put a pre-shaped Lunderquist wire, very stiff wire, through that pigtail into the left ventricular cavity. You see that here, 2-chamber view. And now we are already here in place with the valve system. Nose cone is already in the ventricular apex, and now we open the ventricular part of the valve. We counterbalance that. You see that the hands are moving quite quickly. And now the ventricular portion is brought to the ring. The ring is brought to the mitral annulus, and then the atrial portion of the valve is deployed. Now you see that. The whole system is then removed from the ventricle, brought back into the left atrium. And now the wire is removed from the ring. This is quite easily done. And then the final step is the control of the result. And usually we do that by echo. And you see that there is still a small catheter crossing the mitral valve at that stage. So we see a little bit of regurg here around the anterolateral part. And now you see the fluoro with a lot of extrasystole, but no regurg. And here, when you look on the left upper corner, we see now the atrial part of the valve in the true echo imaging, which is nicely adapted to the atrial wall. And you see how stable the ring and the valve is within in that heart. Here you see the tri-leaflet valve from the ventricular view in the echo. And I think the movie is stopping with a final echo result. And as already pointed out, there is basically no regurg in any of those patients. You see the native valve again, and no regurg. I think you might appreciate that on the last echo imaging.
Okay, thank you, Wolfgang. I believe you have one slide also to share with us.
Yeah, I think somebody has to do that for me. It will come here, yeah. I think that's a very important slide. It shows a single center experience. We did so far 8 cases, and on the left side, you see the different steps of the procedure highlighted in different colors. And I just want to focus on the dark blue bars. These are basically monitoring the time we need for looping with the wire. And I think this is the novel part of the procedure, that we have to steer a wire through the left ventricular cavity, being close and approximate to the mitral annulus and not being trapped. And as you see here, and this is basically summarized on the right lower part of the slide, is that the time for wire looping if you get experience, and the experience is pretty fast, you see after 3 or 4 procedures, we usually manage now to loop with a wire within 30 minutes. And I think this is a very important step that speeds up the procedure, and nobody has to be concerned after a specific training that wire looping is really a tricky thing. Everything is well controlled and well thought through.
Thank you, Wolfgang. So, maybe why don't we stick on that idea and that slide you had about your learning curve with looping, and that in fact is the first step of the procedure. So maybe we can, comment on the various aspects of the procedure. What do you think was the key factor leading to that reduction in looping time?
Yeah, I think it's experience. It's experience and just going in steps. And it was a pretty short part of the talk, but I pointed out that we use different pleural views and go usually slowly with a wire around the mitral annulus. And then if you take your time at that step and don't go too fast and control everything, you can very well control this part of the looping. And as far as I recall, in our cases, we never had to do the looping again because we were very careful about not ending in traps and some other structures. So we were able to catch all the cords. And I think this is not only applicable to Ulm, this will also be applicable to other users of the system.
Wolfgang, one of the important things I think we need to mention is that all of these cases have been teleproctored. And so I've been teleproctoring the HighLife case from home or from my hospital in Montreal as a result of the COVID. And in order to somehow, I would say, get a protocol underway, I think it was very important to understand the imaging. And using a dedicated imaging protocol, going from a 1-chamber, 2-chamber, and 3-chamber, and we'll hear also from David and Stephen what you guys think about, the imaging protocol. But, I always remember the story of asking Fred St. Gore, who was one of the founders of the mitral clip device, back in 2003, 4, 5, 6, those procedures used to take 5 to 6 hours. And I remember asking him what was the reason or what led to a reduction in procedure times. And he said, Nico, he says, you need an imaging protocol. And so, one of the things I believe that has brought down the procedure time is a dedicated imaging protocol.
Nico, just to extend your comments and Wolfgang, so I agree with them. The thing around experience is interesting because it is a different procedure. It's not like TAVR, for example. So investing the time and understanding as to exactly what does a wire look like when it's succeeding on the fluoroscopic image and what does a wire look like when it's losing is really important. Wolfgang, you showed a great image of, it was a 2-chamber view. It was as you were coming around the lateral wall, and you could actually see the wire going toward the apex of the ventricle versus staying to the side. That for me was such a key piece because I could remember in our first few cases that we were doing, we'd think the wire was looking good, and then we'd finally go around to a different view and we'd see it's right down toward the apex of the ventricle. Very quickly you mandated that we must use that 2-chamber view for that second step of the wiring. And it felt like it just took tons of time off the procedure.
Right.
Yeah, it was the thing I was most worried about, I must say, when we were going to do our first case, the potential humiliation of totally failing to make this loop. So actually having Nico explain, okay, LAO caudal, 1-chamber, now go RAO cranial, 2-chamber, now come RAO caudal, and actually it worked, and it was a revelation, thinking, okay, fine, so I'm just pushing it northeast now, okay? And actually it was not the difficult scenario that I had expected. So I think having that imaging protocol really helped that bit, and allows us now to feel much more comfortable going on to further cases.
Nico, you mentioned also about teleproctoring. But for me, what teleproctoring does is it brings out the best elements of any proctoring, which is the best teachers do not have to do the procedure. The best teachers can explain it verbally. And so, Nico, I know when you're on the video screen, there's no way your hands are going to come in and help us. So, but it has meant that there's been that great discourse and communication between the operators and the experience, and I think it has led to the great outcomes.
And also, just because this is a procedure where every step is actually quite controlled. Yeah. There's no part of the procedure where the blood pressure goes to 20. Yeah. And a proctor might have to intervene if people are just doing totally the wrong thing. So it's all very controlled and steady and organized and logical. And actually that facilitated, I think, the teleproctoring. Mm-hmm.
Yeah, so...
Which you were great at, by the way, but I wouldn't want to say that out loud.
No, definitely not to his face.
Yeah, I also have to comment again, Nico. I think you're a very strong teacher, and you are interrupting at the right times. And this is, I think, what is teleproctoring about, is that another person who understands quite well the procedure or nearly perfect guides you through and helps you to understand all these rather new things. And this brings it then to a very successful and speeded up procedure.
I just want to tell the audience this was not scripted.
No, it says so here.
This was not scripted. I don't see it in the script. But thank you guys. Look, the other interesting part of the procedure is the valve deployment. Let's talk about the valve deployment, because yeah, there's some issues or some interesting concepts about coaxiality. Let's talk about rotational positioning, yes or no. Let's talk about self-centering, yes or no. David, why don't you start?
Yes, I mean, again, that part of the procedure is a tiny bit disconcerting, because you really are having to pull to make sure that the ring comes up as much as it can towards the annulus before releasing the left ventricular, before releasing the atrial portion of the valve. So I think that's a bit where there is probably a bit of a learning curve to be done, and it'll only be really once we've done maybe 5 or 6 more cases that we'll have a good idea of exactly how much tension you need to apply. But it's more than is entirely comfortable.
Steve?
Well, Nick, I was going to extend just in terms of the valve release, the point of where you actually do the transseptal puncture, for me, is a really important part of that, so that you can get, as best you can, coaxiality with the left ventricle. So when you're pulling back, you're not pulling down too inferiorly, although you will pull a little bit. Yeah, no, those CT images that you go through really can inform the entire procedure before you even start, and so that you have no unexpected or unplanned mishaps occur.
And maybe Wolfgang, you want to just say something about the deployment steps and having to be coaxial, not having to be coaxial, how the valve releases.
Yeah, I think overall, I think what's different is there is no rush in the procedure. So you have a lot of time. Once you have your ring in place, you can go very well controlled and slowly, step by step. Even after you opened the ventricular portion of the valve, nothing is happening. You are not obstructive to the native mitral valve at that point. And then bringing the valve and the ring back to the native annulus, I think this for sure is a tricky part. And it was already pointed out that the transseptal puncture is key thing, and this is also great in the imaging protocol that we focus on that. After we have the CT scan of the patient, where will we put our puncture and what angle will we approach to implant the valve into the patient? But so far we might have been lucky. It was never troublesome getting the valve into place and deploying it at the point we wanted to have it.
Yeah, we're just looking for some interesting questions from our chat line. But yeah, just to reiterate, you know, the valve does not have to be rotationally positioned. As you're pulling back, you don't have to be centered across the ring, right? And upon release, because of this ring concept, it self-centers itself. And so, you know, I think this is unique in the transcatheter mitral valve replacement field, where you do not have to be coaxial while replacing the valve.
So there's a question from the chat about aortic regurgitation. So whilst you have the catheter across the aortic valve and you're forming the loop, etc., how often does that cause significant aortic regurgitation?
Stephen?
Yeah, look, it's a great question, actually, and there is an important part of the procedure that is the hygiene of watching closely on the transesophageal echo. Is that large loop placement catheter, which is across the aortic valve, is it potentially scaffolding one of the leaflets and causing significant AR? Can I say, though, that with taking significant care during the procedure, that I haven't seen that being a problem. But it is very important to be aware, because if you're not and you have too much tension, particularly if the loop placement catheter comes out and you've just therefore got wire, the theory is you could cause some aortic valve injury. So it's a good question to ask. I think with good hygiene to the aortic valve, you can avoid a problem, but you need to be aware.
Very good. Okay, so why don't we go on with the program. David, maybe you can give us a clinical status update about the HighLife system.
I will do that. Okay, good. So a few minutes of the update of the clinical program. Here's the amalgamation of 2 different studies across 3 different continents, which so far, up to mid-September, has accumulated 65 patients, partly early feasibility in the US, which was 15, and then ongoing feasibility in Europe and Australia, 50 patients there. You can see a lot of sites involved in this program now, a great deal of interest in the technology, so 45 sites currently looking to enroll patients in this study. So the 30 consecutive patients out to September so far have an average age of 75. No particular surprises there. The vast majority are due to secondary or functional mitral regurgitation, 90%, and the usual smattering of atrial fibrillation and diabetes. The key stuff that you're interested in: technical success, 27 out of 30, all with remote proctoring. All the patients left the lab alive, which is obviously a good start. Successful delivery and retrieval of the systems in 28 out of 30, and success free of emergent surgery in all but 1 case. So I think, given that these are essentially all new sites coming new to a novel procedure and being taught remotely, actually these results are extremely impressive for a new technology. If you look a little bit further out to 30 days and then beyond, so several patients have died, and there have been occasional cases where there have been problems. We were just talking earlier about the aortic valve. 1 patient had some damage to the aortic valve and actually ended up having a TAVI implanted. 1 patient had embolization of the valve and required open surgery at the time of the procedure. A couple of patients have gone on to have an atrial septal defect closed. This is obviously a potential feature of something where the implantation apparatus is of a reasonable size and will diminish, of course, as the size of the apparatus becomes smaller. This is, I think, very impressive data looking at the mitral regurgitation over time. So here you have the baseline with the vast majority of cases, of course, in grade 3 or 4. and then out at 30 days, 3 months, 6 months, and then the 5 patients who are out at 1 year, we're seeing basically none or at worst trace in all the cases. So this is a highly successful cohort. In conclusion, I'd say the first 30 interim data cases show that it's a very successful implant procedure. It's been done to a high standard by new teams in a new setting and with a new way of getting proctoring support. Good technical success, 90%, in what was a high surgical risk population, because of course these patients were all considered inappropriate for open heart surgery. The primary safety endpoint and the primary efficacy endpoint were both excellent. Thank you very much.
Okay, thanks, David. So maybe Wolfgang, if you can just give us some small comment about your ideas about the first 30 patients who underwent the HighLife procedure.
Yeah, I think everything is pointed out already. These are very, very encouraging results, and the one big thing is that it's not a single center experience. Many centers were opened, and since everything was planned very well and the system itself is very reliable regarding its technique and its material, we end up with very encouraging results. And if you compare that to TARE procedures or other procedures on the mitral valve, it's very encouraging that we end up with basically no MR in most of those patients. And the procedure itself looks very, very, very safe. And the complications that were described, like valve embolization, these are technical complications. These are not brought with the system, but usually happen with small mistakes by the operators, and then that's kind of natural in real interventional medicine.
Yeah. So maybe why don't we look at the 3 parts of the presentation, David? You start off with the clinical demographics. Stephen, you know what you saw there on that table, is that representative of what we're seeing nowadays for patients undergoing transcatheter mitral valve replacement? Did any of those characteristics strike you?
No. I mean, it's an at-risk patient population. Predominantly a heart failure patient population, functional MR. Look, it's a group of patients that we know. It's the degree of MR mitigation in the therapy that we undertake is going to be crucial in terms of what their outlook is like. Edge-to-edge technologies, which have been a great advance for the treatment of patients with heart failure and significant MR. We do know, if we look at the mortality benefit, that the adequacy of the MR reduction is linked closely with their mortality. And even a 2+ or greater MR, not just 3s and 4s, actually portends a worse outcome. So for me, the other bit you're going to go to, which is the efficacy of the procedure, is striking. I mean, not one patient has had a 2+ or greater MR at the end of their procedure.
No, it's very impressive.
David, do we have any
Yes, there's a good relevant question about screening failure. So the question is basically, why are patients not being accepted into this program if they fail screening? What are the main reasons for the screening failure?
Yeah, sure. So Wolfgang, you've submitted several patients for screening. In your experience, what have been some of the reasons for screening failure?
I tried to point it out at the beginning of the video. So we, and I think every center is now pre-screening their own patients, and certainly there is a diameter limit to the mitral annulus. It's around 45 millimeters. That might lead to an exclusion. We measure the neo-LVOT area, and it should be above 200 square millimeters. And if it is not the case, patients are excluded. And we also still measure the distance of the implanted valve to the intraventricular septum, because we still think that the device shouldn't touch the septum. And I think this is very smart to look at these features and exclude the patients at such an early stage of the procedure and the program.
Yeah, I tend to agree with that. I've been involved in some of the screens, and it does look like annular range and LVOT obstruction continue to be some of the pitfalls or screen failures that we see. On that note, Stephen, why don't you...
It's a great segue, Nico.
It is. Why don't you tell us about what are some of the unmet needs and what HighLife might be doing in order to meet those challenges?
Thanks, Nico. To that exact question that we asked, what are the cause of the screen fails? Because we have seen that in this trial to date, only about 1 in 6 patients that have been submitted to the core lab actually are getting accepted. Well, as you can see on this graphic presentation, basically exactly what you heard from Wolfgang and Nico is absolutely correct. Basically, there are 2 major determinants of a patient not being accepted for an implant with the HighLife device. One of those is the potential risk from the modelled CT imaging, that there's a perception that there would be a significant risk of left ventricular outflow tract obstruction. And without going into the detail of it, it was an algorithm that included the potential neo-LVOT area, as Wolfgang mentioned, of 2 square centimetres, or an average distance of less than 8 millimetres. But the second major issue was the annular dimensions. So in this patient population that we heard before that were predominantly heart failure, often their ventricles are significantly enlarged, but the mitral annular dimension needed to be less than 45 millimetres, and so that was the second major cause. So clearly, in order to manage that, we're going to look at what potential advances will we look to see that could address that. Well, the first of them, if I talk about the left ventricular outflow tract obstruction, we alluded to this a little before, there's an iteration which is called the clarity valve, where because of the ring and valve unique concept, we know that we're causing paravalvular leak mitigation actually where the ring sits within the stent frame and interacts with it. So therefore, the skirt on the stent frame on the ventricular side of that is in theory redundant. So we've actually removed it. And if you look at what that has led to in some of the animal model studies, well, then that proof of concept appears that it might occur. I've got 4 images here, but I want to draw your attention to the top 2 images. The one on the top left, for example, if you can see my mouse here, this is actually a standard HighLife valve, and you can see the blue colour flow Doppler that is going through the outflow tract is only occurring outside the valve frame. But if you actually look to the image under the clarity valve to the top right, actually I think with the eye of faith you can appreciate that there's actually a stream of blood now going not just through the neo-LVOT, but actually through the device itself as well. So in theory, providing us a solution for patients that may have a perceived small neo-LVOT. The second issue around valve sizes, when we've looked at that number of patients that have been submitted but rejected, when you look at this data set, you'll see that actually by having a valve size that would only increase by 7 millimetres, so taking the inclusion from 45 millimetres to 52 millimetres, actually 98% of patients would be amenable to now the valve technology. So clearly getting another valve size would be of benefit, but potentially it may only be 1 extra valve size that would be needed. So to address that, the program actually will start in the beginning of Q1, so in January, that Clarity, or what's called the High Flow program, will start enrolling. In fact, the very first patient has been screened and accepted, and in theory that first patient will be treated at the end of January. But then shortly after, the beginning of Q2, early in the calendar year, we'll see that new large valve frame being treated as well. All of that leading toward a potential US pivotal large trial looking for FDA funding to begin in the middle of 2023. And if I actually just put you for the last one, just to give you a teaser for that potential, what may be a global trial of a second-generation valve delivery system looking for FDA approval versus sort of an optimal performance comparator. So it would invariably be a single-arm trial, but against whatever a optimal performance comparator would be. Looking for primary non-inferiority versus clinical endpoints, but superiority for MR based upon some of the information that you saw from David before. Thank you.
Thank you, Stephen. So, you know, it was pretty striking that 80% of patients are being rejected on the basis of annular range and LVOT obstruction. So, David, you know, Stephen presented these two new concepts. You know, what do you think it's going to do to the screen failure rates? Where do you think it's going to shift?
I mean, definitely it's going to come down, and that's very welcome because, of course, what you don't want to do is find that you've done a procedure and you've garnered new skills, and then there's a time delay of 2 or 3 months till your next case, and you kind of have to gather your skirts up again to relearn what you did before. So I think it's going to be incredibly welcome. I think the range of size increase will make the biggest difference. The question over clarity and how much that helps avoid LVOT obstruction, I mean, obviously the anterior leaflet of the mitral valve is still there. So, you know, we'll have to see about that. But I'm looking forward very much to being able to have a rolling program now of implants that we can be confident, okay, every month, every 2 months at worst, we're going to do another case. And by the time we've done 6, 7 cases, we'll probably actually start to be reasonably adept at it. I hope.
Yeah, you know, Stephen, you showed that echocardiogram where there appeared to be flow going through the cells of the HighLife Clarity valve. Do you think that's because the anterior mitral valve leaflet is sort of, you know, tethered up as you pull up on the valve, or do you think maybe there's still leaflet across the frame?
Look, it's a great question, and that's why we do the study to see. To David's point, whilst there's that potential risk, the way the procedure's performed does potentially facilitate that tethering or gathering of the anterior mitral leaflet up, so that it may well be taken away, and therefore you're just left with cords. So yeah, I do think the concept is potential that's exactly what we would see. So I look forward to. Well, certainly this time next year we'll have had those 15 patients treated and seeing what the results look like.
Yeah, Wolfgang, you know, the larger valve size, you know, when you look at it, it has a larger atrial hat, let's say. You know, so in fact, what we look for is a cover index so that atrial hat can sit on the annulus, right? We don't rely on oversizing. So do we see how much of the annular range you think we might extend to?
Yeah, I think that's a difficult question. I think early in the symposium we pointed out that the ceiling is taking place between the ring and the valve, or the neo ring. So just increasing the atrial portion will not affect a lot of the sealing mechanism we see so far, and therefore I think it's a very good approach to come with a little bit bigger valve and a little bit bigger diameter that can be implanted in those patients.
Okay. Do we have any questions from the chat?
Yes, one question raised is will the fact that there's a bigger device make any difference to the proportion of patients that are actually turned down for LVOT obstruction? In other words, implying, okay, if it's bigger, surely there's going to be more LVOT obstruction. So they're wondering whether there'll be a parallel increase in turn down for that.
Stephen?
Look, it's a great question. If I look at my experience and comments around the sorts of patients that have been missing for outflow tract obstruction versus those missing for valve size, they've tended to be different. The ones missing for LVOT obstruction have tended to be more preserved ventricular function, smaller ventricles. So I think that's made that worse. Whereas the larger ventricles, I think, haven't. They've tended to be greater space, both sides of the valve, if you like. So it's an interesting concept. I'll be interested to see when we data. But my feeling has been that they've sort of been one or the other.
Okay. Do we have any further questions from the chat?
Oh, yes. There was one about conduction defects, about whether we would expect to see it. I mean, there was one patient in the study who had a pacemaker implanted subsequently, but comments about expectation of conduction defects. I mean,
no,
not really.
It really hasn't been a problem. Of course, the conduction tissue is very close to the mitral valve. It's very close to the right fibrous trigone, close to the A3 component of the anterior mitral valve leaflet. We probably see it more often with surgical mitral valve replacement. But in our study, we saw 1 out of 30. Yeah. So I don't think it's going to be a big problem.
Nico, in fact, I know that patient actually was a patient from one of the centres in Australia, and in fact, it's a patient that had significant conducting system disease before, and on reflection, probably was a candidate for permanent pacing prior to the procedure. It wasn't done, and in fact, there was nothing that actually happened intra-procedurally that suggested that there was something that was there. In part, it was facilitated because the patient was actually in the hospital.
All right. Okay, so why don't we go over some of the key learnings of the session and bring the session to a close. So, we saw that the HighLife transseptal mitral valve system is a valve in a ring concept. It's delivered through a transseptal pathway, which is very attractive. Currently, we've done over 30 patients. All of these patients have been teleproctored during the COVID pandemic. The results have been very encouraging, we can say. The screen failures, mostly due to annular range and LVOT obstruction. And as you showed us, Stephen, there's some new devices on the way, such as the Clarity valve that has a cutout skirt, if you will, and a more open cell design in order to allow more flow across the outflow tract. And also a larger valve size that hopefully is going to fill the other gap in screen failures. So I want to thank everyone for joining us here this morning, both live and virtual, and we'll see you in the next session. Thank you.
Great. Cheers.